Fantastic. Thank you.
Great. So good afternoon. Thanks very much for joining us. The first of the Maternal and Child Health Research Institute 2022-23 monthly seminars. We are so lucky to have Dr. Malathi Srinivasan and Dr. Sellers joining us today to talk about the Center for Asian Healthcare Research and Education, which we'll get to in just a second. Really excited to have them present today. What I'd like to do is go through a little bit of housekeeping though. This is our thanks. I want to make a big thank you to our MCHR Education Committee shown here, and really provide an enormous amount of insights. Please, if you are interested in having a suggestion for a topic, please reach out to one of the committee members, and also are happy to join, please let me know. Next slide. Want to point out that we are having our 5th annual MCHRI Research Institute Symposium on Thursday, October 20th from 8 to 3:30 in person. The key is in person at Li Ka-shing Center. But really the focus is going to be on community engaged research, where we have really an all-star in-person cast of community engaged researchers, including the Alicia Perez-Stable, the director of the National Institutes of Minority Health and Disparities, Nina Wallerstein, who directs one of the standing programs in the University of Mexico, Alonzo Plow from the Robert Wood Johnson Foundation, and Nikayla Cook, who's the executive director of PCORI, actually in person at LKCC. So please register. There's also abstracts that are due today if you want to present. Each of the abstracts for the poster session will be mentored and presented for the group. And also 5 will be selected for oral presentation. So please, by the end of today, submit your abstracts for presentation. And this is going to be an amazing in-person event. Next, I really want to point out that we're now taking applications for our 2nd MCHRI Eureka certificate course in translational medicine cohort. And by cohort, we mean a group of 30 junior faculty that want to do translational research, where we equip you to do that in a 4-day course down in the Silmar. It's really a comprehensive and immersive learning experience, and for instructors and assistant professors with at least 50% protected time. So please look for this on our website. It really is a transformational course and will equip you to really do basic and translational research for maternal and child health. So please, and contact any of us if you have questions about it. And then lastly, the D3 training course. D3 is really the MCHRI's interaction with industry, where internships equip you to work, fellows to work in industry and then come back and then develop products. So the applications for that are due October 2nd. So please look into this if you have any other training or interest in the sort of real world hands-on industry, academic industry interaction. But today, really, we talk about, Dean Miner talks about the social and behavioral determinants of health, and not just the genetics, but also the surrounding microenvironment of the individual that modifies and mediates the phenotypes that are expressed. And there's no better example of that than the Center for Asian Health, Healthcare Research and Education, that's directed by Malathi Srinivasan, so who will talk about it today. She's here with the Assistant Professor of Pediatrics and GI, Zach Sellers, who will present a really focused vignette about the things that she's talking about. So without any further ado, I'll give it over to Malathi to basically present. There, as always, there'll be a time at the end for questions. So please put them in the chat or the question answer period at the bottom, and I'll moderate that. I think this is really an example of not just one ethnic group and a disease, but also really a model for the social behavior determinants of health going forward. And so we hope we'll learn a lot today. So Dr. Srinivasan, please take it away.
Great. Dr. Oro, thank you so much. And thank you also to co-presenter Dr. Sellers for this lovely opportunity to be able to share with you our work at the Stanford Center for Asian Health Research and Education. We're really excited by it and excited to share that passion with you as well. I'm a clinical professor of medicine and a program director for the Stanford Care Scholars Program and associate director of this new center. And today I'm going to run through a brief history of Asian health and healthcare, talk a little bit about Stanford Care, about our Care Scholars Program, and then talk a little bit about some collaborative opportunities and seed grants that are available. I'll then turn it over to Dr. Sellers, who's going to talk about a focus project he did in Asian health, working with our Stanford Care Scholars. And we're really excited to share all of this with you. So I hope you will share this passion. And first, again, thank you so much to MCHRI. We're so honored to launch your seminar series. And I hope that we'll have a great time together. Okay. So the first thing I wanted to define Asia. People are always confused when I talk about Asia, what actually includes. It includes everything from Russia to Saudi Arabia and China, and Southeast Asia, India. But when we think about Asia, from the continental perspective, we've got North Asia, which is Russia, West Asia, which is what we consider the Middle East, South Asia, which includes Pakistan, Bhutan, Central Asia, East Asia, which is mainly China, Korea, and Japan, and then Southeast Asia, which is Vietnam, Cambodia, Laos, and a lot of other Burma, Malaysia, Indonesia, East Timor, and others. Okay. So I hope that helps as a definition. So we're only concentrating for this talk on South Asia, East Asia, and Southeast Asia. So the thing I want to mention is that Asians are really 60% of the globe. They are 6% of all of the people in the United States and are the most rapidly growing ethnic minority group. And they're 30% of the Bay Area. They're actually 17% of California. So it's an important population that's been growing in numbers, mainly through immigration over the past 2 decades. But here's the rub. Here's the rub. If this was an open panel, I would ask, what percent of Asians actually are represented by the NIH, and what percent of NIH funding goes to Asian health? And the answer is less than 1%. It's 0.17%, despite being 6% of the population, and more than that for the income payer base. So it's a minute number, and this is for a lot of different reasons. Asians are overtaking Hispanics as the new immigrants, but they don't participate in clinical trials globally or within the United States. And so it really becomes a bit of a problem because Asian healthcare decisions are made with non-Asian data. We find this happening with genomics and with really all kinds of other populations and every other type of health measure that I'll go into a little bit later. So, the problems with Asian research and data is that data is aggregated. And there's 3 different things that happen. We have things that have to do with omission, which is there's a lack of Asian Americans in surveys and health data. So we don't actually know what the health risks are. Aggregation, where people from all of these different countries are grouped all together as Asian Americans. And it really masks health disparities that we need to disaggregate because the lifestyles of all of these people, both from original countries and people who are within the United States, is often very different. So there's both genetic issues as well as personal lifestyle issues and some global trends in community health behaviors. And then the third is extrapolation. This is where data from one group is inappropriately applied to another group. And a classic example of this is the Nihon-san study, which studied people who were Japanese from Japan, Hawaii, and also from San Francisco, and then applied all of those results to everybody else who was considered Asian. And so it's masks disparities and makes incredibly broad generalizations that are often inaccurate. So these major disparities in health outcomes have happened because of a lot of structural issues. And what I thought we could do is talk a little bit about how we got here for just a few minutes, and then go into some of the programs that we have at Stanford Care that are trying to address some of these issues. So Asians have been in the United States for a very long time. The first known Asian, was in 1587 when a Spanish galleon landed in California, and there were 2 Filipinos as part of that party. They were attacked by the Native Americans, and 1 was killed. Let's see if I can move this further. I think my screen is freezing. Give me a moment, please. Okay. But then really the first recorded settlement in Asia was Filipinos in Louisiana. Then that was in 1763. Then by 1790, we had the first immigrants. Then first recorded Chinese immigrants who were starting to come over as the railroads were being constructed were in 1820. And we had someone who actually graduated from college, which was very unusual for a Chinese American, a Chinese person in America who was Chinese from Yale. And then the gold rush really led to a large-scale Chinese immigration. By the increase in influx of people who were Chinese, who were taking low-wage jobs, threatened a lot of the people who were white miners and workers. And Congress, the California Supreme Court, there was a lot of violence against Asians, actually created a rule that said that Chinese couldn't testify against whites. And then by 1858, California barred Chinese immigrants. Asians have a long history of having massive violence against them. The Rock Springs Massacre in Wyoming in 1855, 115 Chinese miners attacked and killed their co-workers. Rioters burned almost all of the Chinese homes in the area. And then moving forward, if I can get my screen to advance, the largest lynching in America was actually in Los Angeles in 1871, where 500 white and Hispanics attacked Chinatown and Negro Alley with a total population of Chinese were 172. And they killed 19 immigrants, including a young boy, and lynched 15 of them, most of whom were already shot dead. So by the almost 1900s, the US was at war with the Philippines, invaded Hawaii, and took over after winning the Spanish-American War. And the US became one of the countries to begin naturalization of native-born people, which is the majority of countries do that nowadays. But later, they excluded people who were Japanese about 20 years later. And there was segregation of Japanese, Chinese, and Korean children. And by 1907, Japanese and Koreans could no longer enter the US mainland. By the time we hit World War II, we know the history of what happened with the Japanese internment with 2 orders, one to remove people from their homes, and the second is to intern them. And the majority of these, over 130,000 people, were US citizens. By the time we're entering the Vietnam War with Indochina, about 130,000 people had fled as refugees to escape China to communism. And then over the next few years, we had about 3 million people from Southeast Asia immigrate from Cambodia to Laos and other places too. Hawaii had the first Japanese American congressperson and the first female congressperson as well. In 1965, the Immigration and Nationality Act eliminated national origins quota systems. And at some point in time in the next few years, mixed marriages were actually between different races were actually allowed, which were illegal for a very long period of time. In 1968, Yuji Ichioka, who was a Japanese American who was interned with his family in Utah, had coined the term Asian American, which previously people had called people Oriental or people from the continent Asiatic, in part to get over the history of racism of Asians against the US, but also because it was important to come up with a term that would breed solidarity from all of the people within those areas that were facing discrimination, and in a way to unify the Asian community. I'm going to just call out a few different types of immigration patterns. People of different ethnic origins from different countries came over. We mentioned people from Vietnam or Indochine coming over after the Vietnam War. People who were Korean began coming over mainly in the 1980s, and then increased in the 1990s, as you can see. And then people who were South Asian began coming over in the 70s, And over time, those populations grew as well. By 1999, Andrea Young was the first non-white CEO of a Fortune 500 company, which was Avon. And then the 2000s were really a period of greater acceptance to some degree of Asians in the United States, but still fraught with a lot of problems, with people who were Asian American cabinet members and American cabinet members, with Labor Secretary Elaine Chao. And then Bobby Jindal was the governor of Louisiana, and President Barack Obama appointed 3 Asian Americans to his cabinet, which was previously, quite unheard of. And then, but if we kind of go back a little bit, around 9/11, there was a lot more violence against South Asians before it had been limited mainly to East Asians. But there was still a lot of violence and discriminations. And I can tell you, growing up in the Midwest in the United States, there was quite a lot of anti-Asian violence against South Asians, East Asians, and Southeast Asians. And it was very difficult, but 9/11 really precipitated a greater divide and increasing Islamophobia. So by the time we're reaching the 1910s or so, there's an increase in Asian activism, where Lynn Ditch, who was a professor at University of Miami, had mentioned that Asian and Asian Americans are often left out of political narratives, including civil rights movement, which prevents really Asian and Asian Americans from being seen as a generative force for political rhetoric and for change. And this goes even with the depiction of Asians as really either bumblers or overachievers in movies and TV. So as we move forward in time, we find that Nikki Haley became the first Indian American female governor. And we have the first non-white CEO of a major Hollywood studio, Warner Brothers, in 2013 with Kevin. I'm going to move forward, and of course, we have to mention Kamala Harris, who is now our Vice President of the United States, who is half South Asian and half African American. So, I guess one of the big questions is, what does this mean really to be Asian in American society today? And you can see the depiction of Asians in America and around the world has really changed over time, from really the bumbling stereotype of someone who's unable to assimilate, to people who are either high achievers or who are superheroes now and have movies made after them. But one of the major problems is this idea of the model minority myth, where every Asian who, because of the way immigration happened, especially for South Asians, where people were really only allowed in the country if they had a higher education or if they came in with some assets. A lot of people were seen as model minorities, which perpetuated the idea that if you were Asian, you must be high achieving. And if you were high achieving, your health and other issues were not worth studying. And so it both put incredible pressure on people who were young, but also made people who were empowered disregard the health needs and societal needs of people who were Asian in America. So the pandemic really accelerated violence against Asian Americans and Pacific Islanders. And I think we've seen a lot of that over the past few years, even now with people getting attacked, and it's been very challenging for the Asian population. And another major problem that's happened because, again, of this model minority myth and this sort of blindness to people who were from other cultures, from non-European cultures, the US definition of white included the Middle East and North Africa, but for Asians, it really aggregated Asians for a very long period of time. And this disaggregation, which is from, I think this is from NHIS, is fairly new. And also until like in the 1870s, all of the people could be white, black, mulatto, Indian, Chinese, or Japanese. And then by 2000s, at least the 6 major Asian ethnic groups were included separately. And you could write in something if you were either multi-ethnic or if you were a part of other groups too. Okay, so that's a really brief overview of kind of how we got to where we got, where we are now. And I'd like to review just a few issues with Asians in America and Asian healthcare. Now, I showed you these slides before, but I hope they have a different relevance to you, having seen some of the history of Asians in America. Now, there's 6 groups that make up about 85% of all of Asian Americans in the United States. And again, their health needs are very different. And for the majority of places, including at Stanford, all Asians are aggregated. So we actually don't have demographic data from Stanford on people who are from the different countries in Asia, if they're multi-ethnic. But we do from Kaiser and from Sutter, which is Project Dash, which I'll get to in a little while. So people, although all Asians on average seem to have a higher median income than Americans, when you start disaggregating them, you see that it really varies from people who are Burmese and Nepalese who have fairly low median incomes to ones that are much higher. And when you start looking at percentiles, even within that, within people who are within 200% of the federal poverty limit, what you'll see is people who are Korean, Vietnamese, and Chinese have a lower percentage of people have a higher percentage of people who are in poverty in comparison with the 76% of non-Hispanic white who are above 200% of the federal poverty limit. And similarly, we see the same kind of things with education, and we start seeing the same type of thing with different disease states. Now, I know this is a maternal fetal audience, and so I'll get to that data in a minute. But so when we look at coronary artery disease, for instance, if you aggregate all Asians, the numbers look, probably about the same as people who are non-Hispanic white. But the moment you start to disaggregate them, and I think that my disaggregation data slide has fallen through, you would see massive variations. I don't know where all the arrows went, guys. I'm sorry about that. I'll send that to you later. You'll see massive variations in coronary artery disease with people who are Asian Indian having 4 times the risk of coronary artery disease than non-Hispanic white. And this is important because there's major mutations in all of the different groups from that impact pharmacogenomics with, like say, with Plavix and other metabolism to things with breast cancer, lung cancer, asthma, with variable efficacy of beta agonist, seizure disorder, lung cancer with EGFR being more common in East Asian ancestry. And so what we really see is variation in almost all of the different health outcomes. And same thing with diabetes. And this is a recent study that was in JAMA Network, a JAMA Open Network, on disparities in adverse maternal outcomes in Asian women in US delivering at term. And what they really found were great variability with the majority of the outcomes, but especially across the board, higher risk of anal sphincter injury in the peripartum period. And this is a study from a couple of years ago that also showed even when adjusted for education and adjusted for income, there were increased complications when in comparison with unadjusted rates. This is based again on the CDC and National Vital Statistics programs on peripartum hemorrhage, uterine atony, severe perineal lacerations, maternal comorbidities, and a lot of increased procedures and a higher mortality rate at 1.72. And this is happening with a lot of young people who are immigrating for tech jobs and other jobs around the country from Asian countries. So I'm not going to go into all of this. I'm just going to sort of show you these, that you'll see sort of the difference in cancer rates. For instance, if you are a 50-year-old Korean man coming in to your doctor in America, you're going to be offered a colonoscopy when your risk of colon cancer is probably much lower than someone who's non-Hispanic white, but you probably need an endoscopy because your risk of esophageal and gastric cancer is much, much higher. Okay? And I could go on. So, there's a lot of ways of solving these problems, and, using the national data sets and electronic health records are useful. But again, because of problems with the way race is reported and ethnicity is reported, it's really tough to do this. I'm going to skip all this. Okay, so we have at our center quite a few people who are working on different aspects of these problems, from Dr. Prophet working on maternal infant mortality, and Dr. Sellers, of course, did a lovely study on cystic fibrosis in Asians, and people who are working on different aspects from a primary research perspective. But I wanted to emphasize that decisions around Asian health is really made using population data at this point in time, and we're trying to fix that in a variety of ways. And that was really part of the genesis of CARE, which is to improve the care of Asians everywhere. Now, I showed this slide to you because this is Dr. Latha Palaniappan's father, who died when she was a teenager. And he died of a heart attack, and he was in his 40s, his early 40s. This really shook her and her family. When she was in school and studying, she really realized that there was almost no good data explaining why her father had died. And as she had moved into Asian health disparities as a field, she and Bryant Lin had about 5 years ago founded CARE, which is the Stanford for Asian Health Research and Education, which was the vision of which is to become the premier academic leader in precision Asian health to improve the health of Asians everywhere. And it's really kind of through creating knowledge, empowering education, and impacting their clinical care. And so we've been around for about 5 years now and have done very well, both in terms of our impact for publications, over 100 papers published by Stanford CARE faculty in the past 5 years. In terms of education, which I'll talk about in a minute, we're giving out a lot of seed grants. We've got about $10 million of follow-on funding on top of the major philanthropy that we have been able to, that's been generously donated to the center. And I'll tell you a little bit more about all of these, but we've been very proud of the growth that's happened, which really started with a coffee shop conversation between Latha and Bryant, where they were both talking about problems in addressing Asian health, since the majority of centers around the country have been really single institution focused or single group focused. So I'm going to skip through a lot of these. I'm a health services researcher and medical educator on top of being an internal medicine person, and love building programs. And so although Asian health was a new field for me, they had asked me to help lead a nascent CARE Scholars program, and our team has grown quite a bit. We have multiple programs in research, with seed grant increasing from like $5,000 and $10,000 to about $50,000. So both seed and sapling grants, which are about 6 per year. We've had visiting scholars from other countries. We have a major gastric cancer initiative, which is trying to change the way gastric cancer screening is happening in the US, working with the US Preventive Services Task Force. And we have a project that's working with Kaiser and Sutter data called Project Dash, which supports collaborations around Asian and Asian subgroups for both peds, kids, neonates, and adult populations over a whole variety of conditions. The analysis will be conducted in conjunction with Kaiser and Sutter. The only thing you would need is a little bit of funding to support the analyst, but the agreements are in place to make that happen. We've been working a lot on community engagement, from a whole seminar series with different community groups to a project called Nourish, which is where we're crowdsourcing, and Dr. Moni here is working on creating healthy, diabetic-friendly diets in all of the different cuisines. As you know, most Asian foods are most Asian cuisines are very rice and bread heavy. Working with award-winning chefs and other things, and working on caregiving systems. And again, I'd mentioned the gastric cancer initiative that Dr. Juha Wong and Robert Wong are both leading. I'm leading the CARE Scholars program in our Implementation Science Fellowship. We have about 5 courses that we're teaching throughout Stanford. We're working with our APAMSA Asian Pacific Medical Student Group and a bunch of Stanford courses. And we've also relaunched the Journal of Asian Health. So if you have work that you want to publish in Asian Health, it's just getting started again. So it's only publishing a couple times a year, but we think it's going to become the premier journal in Asian Health within a couple of years. And that's led by Paul Wong in cardiology and orthophysiology. So I'm going to briefly talk about the CARE Scholars program and then turn it over to Dr. Sellers.
Yeah, we should give a little bit of time to Dr. Sellers to work. So. Okay,
I'll take 3 minutes. Okay, so the CARE Scholars program is training the next generation of Asian health and global scholars, and it's really geared at undergraduates and early graduate students. And I can make this advance. Give me just a moment. So it started off with just about 5 students the first year, and we've grown it this year to about 24 students. We were able to give 3 scholarships, including some scholarships from our division. And the structure of the program is that, let me skip ahead to this. The structure of the program is that we pair our scholars, which I'll get to in a moment, in teams of 3 with a mentor, and they all work on a research project around Asian health. Each team has 2 projects, and we push them to do publication. So for the first group, we've had about 5 articles published. For last year's class, we've got about 6 or 7 now published and about 6 in review, and we're hoping to get all 16 of our projects from this year submitted within the next year. And with generous foundation from the Chili Pao Foundation, we've also been able to partially support our scholars presenting when they presented at national and regional meetings. So we've been very proud of the work that they've done. So I'll skip all of this. We have a pretty structured curriculum, and of our seed grant awardees, 2 of them were in maternal and child health, Dr. Profit and Dr. Deng. And I'm going to kind of just briefly show you some of the work that our scholars have presented on, and this one was on comparing neonatal mortality amongst Asian Americans, Native Hawaiian, Pacific Islanders. And rather than go through all of this, I'll just kind of zoom through it so we give Dr. Sellers lots of time. Okay. And hopefully what you'll see is that the quality of the work that's been done using the national data sets has been pretty high. And the students work very hard on collaborating with their mentor, and they're supported by an implementation science fellow who are PhD candidates or postdocs who are working with our students. So this is the second one on perinatal outcomes that we're doing this year. And again, the research question is how perinatal outcomes vary among disaggregated Asian subgroups. And I'll just kind of zoom through all of this and not steal their thunder. But the point, I think, is that there's multiple collaborative opportunities for people who are interested in Asian health, from our seed grants and sapling grants to working as a mentor with one of our scholars, working with Project Dash and publishing in the Journal of Asian Health. So I hope that gives you a bit of an overview about things we've been up to for the past couple of years. And with that, I really want to thank Dr. Sellers for his amazing mentorship. He was a mentor to one of our very productive groups last year, and really helped carry the work over the finish line to publication. So with that, thank you, and let me hand it off.
Thank you, Malathi, for that nice overview, and thank you to MCHRI for the opportunity to speak today. Share my screen. So as Malathi indicated, I'm going to share a little bit about a project that
Zach, you're on presenter view, so we want to swap. Yeah, there you go. Perfect. Awesome.
Great. So let me back. So this is the project that I'm going to talk about today that was supported through the CARE program. And I don't have any disclosures related to this talk and the data I'm going to talk about. I will mention that this work was published this year in the Genetics and Medicine, and just this month was featured in their podcast GenePod. So if you want to check it out, you can go there. And of course, from the very beginning, I want to recognize those people that have been involved in the work. And I would say that this project really came out of some initial discussions with Dr. Sriram Vaidyanathan and myself, who Sriram at the time was a postdoc and then later an instructor in Matt Porteous's lab in pediatric stem cell transplant, and is now gone on to Nationwide Children's. And as we talked about this topic, then we were fortunate to become engaged with the CARE program, and we had 3 CARE scholars that worked with us, Lily Barr, Maneha Rao, and Yunan Yu, and together with Annie Trumbull, who was a former member of my lab, worked on the analysis. So to give some background, cystic fibrosis is an autosomal recessive genetic disease and is caused by biallelic mutations in the Cftr gene. And CFTR encodes for an ion channel that primarily conducts chloride and bicarbonate in most tissues throughout the body. It's most notable for its roles in epithelial ion transport, and there, what it does in the across the airway, gastrointestinal, and reproductive tracts is maintains this nice layer of mucus and fluid in the lumens of the organs in which it's present. And so what you see here is that normally when you have good CFTR function, you have chloride and bicarbonate ions that move through. This creates the right pH and hydration environment. So you have this slippery, thin mucus that's able to move through the organs well. And in CF, when you're no longer able to get those chloride and bicarbonate ions to move through, you get this thick, impacted mucus layer that creates inflammation and infection in the tissues. Now, complications from CF result in premature mortality. The current average lifespan is around 50 years now in the US, but it's much lower in other countries and locations where they do not have access to early diagnostic and early treatment options. And so just to highlight this, I would say that, you know, over the last 80 years, there's been remarkable improvements in CF healthcare. And what you can see in this figure here is that the red line indicates that predicted median survival in years. And the descriptions here with the arrows show some key time points in CF healthcare history. From the initial discovery about high salt and sweat, which led to the sweat chloride test being developed later in 1989, to the CFTR gene being identified. And in 2010 in the US, at least, CF became part of newborn screening in all 50 states, although it started in 1982 in Colorado. And then on the other side of this graph, we see different treatments that were initiated over time. And really, these improvements in survival are a result of the coupling of these diagnostic and therapeutic advancements so that there can be early initiation of treatments. It's been well documented that there is delayed diagnosis of CF in Asian individuals. And when I think about this, I think that it really comes across because of and three facets. One, there's a perception that CF does not occur in Asians. And part of that is because there are no CF registries or newborn screening programs in Asia. And so we're reliant on data that comes from countries like the US and other countries that do have registries and newborn screening programs. And so Malathi talked about this, that we're extrapolating data from those registries. And as a result, there's little knowledge on CFTR gene mutations that may occur in Asians. And so there's also this inappropriate extrapolation, which I'll show you, that Asians will have the same CFTR mutations that we may see in non-Hispanic white individuals. To give some context, when we think about this circle here is meant to represent the incidence of CF relatively. And so you have a large population of non-Hispanic white that we know about, relatively less Hispanic in the US, even more so less Black individuals, and then even smaller number of Asians. And this is from data from the US. Now, knowing this, Sriram and I started talking because we had noticed that in our population here at Stanford that we seem to have a disproportionately large number of South Asians in our CF clinic. And so we wondered, well, is this unique to South Asians versus other Asians? And And so that was the problem that we wanted to embark on. And so our fundamental questions were, one, how common is CF amongst different Asian subgroups? At the time, we thought about South Asians versus East Asians, but as Malathi pointed out, there are other Asian subgroups. And do Asian subgroups have similar CFTR mutation profiles as white CF individuals? Now, to look at this, we utilized 3 registries. One is the US CF Foundation Registry, one is the CF Trust from UK, and the Canadian CF Registry. And cumulative, this accounts for almost half of what is thought to be the world CF population, although, as I'll explain later, I think that that's not true. But these were where we thought the data was best annotated, and so this is where we started. So first, looking at the US CF Foundation Registry, when we look at that, we see that almost 92% of individuals are white, and only about a half of a fraction, 0.5% of individuals in the CF Foundation Registry are Asian. And what we learned is that this registry does not disaggregate. So we were stuck with just this large group of Asians. Now, when we look at the UK and Canadian data sets, they do disaggregate. Similar to the US registry, there's a high proportion of white individuals and a relatively smaller portion of Asian individuals. However, when you disaggregate the Asian individuals, you can see that the large majority are South Asians. Now, we weren't able to disaggregate further across any of these groups because while the UK does disaggregate further into different types of even South Asians, Canada does not. And so that's where we lumped many of these other groups into this other Asian category. That was not what we wanted to do, but that's what the data would allow us to do. And so using census data, we then estimated the epidemiology and prevalence of CF in South Asians and these other Asian group. And you can see that there's a wide spread, but these are the numbers that we came up with, which honestly are fairly similar to some of the data that's in the literature about Asians in general, but we do feel like South Asians as a group have a higher prevalence than some other Asian subgroups. Now, how important is this? Again, if only 0.5% of the US Asian population or CF population is Asian, you can think, well, that's not very many individuals. But when you think globally, as Malathi pointed out, if you just look at South Asia, which makes up almost a quarter of the world's population, we estimate that there could be about 26,000 to upwards towards 200,000 CF patients in South Asia. And to give context, there's about 30,000 CF patients in the US and thought to be about 100,000 worldwide. So this would drastically change those numbers. Now, we identified that Asians have different CFTR mutation profiles than the general CF population in these registries. And I'm just going to briefly go over these tables. So what we did is we annotated and looked at all the CFTR mutations in the UK and Canada CF registries. And then we can compare that to the top 10 most common mutations in the UK and Canada. So these tables are only showing the top 10 mutations here for South Asians and other Asians, and over here for the whole registries. And what I've done is I've highlighted the mutations that overlap. And what I just want you to be able to appreciate is that there are very few mutations in those top 10 that overlap. And so compared to non-Asians, Asians have a high percentage of nonsense, frameshift, and splice variants and large deletions that aren't represented as highly in the general population of these registries. And why is this important? Well, it's because that when people make diagnostic tests or people think about therapies, then they will use this genetic information to think about what types of CFTR mutations do we need to target. And so if you're not represented well in these data sets, then you're going to be left behind. You'll see. So these differences in CFTR variants drive diagnostic disparities in Asians. Genetic testing is integral to making an initial CF diagnosis. And so what we did was we looked at, there are a number of different CFTR gene panels that are used, but there's two that are most commonly used in the US and Europe, and that's the Hologic and the EU2B1 panel. And so we just took these panels and the mutations that they cover, and using our mutation data set, asked the question, what percentage of patients will be detected if using these standard panels? And what we found is that, approximately anywhere between sort of generally 50 to 60, sometimes up to 70% of South or other Asians would be detected with these panels. But yet that leaves sometimes up to almost 50% of individuals who would not be detected. And as a thought process, we said, well, what happens if we add the top 5 mutations that we identified from our study onto those panels? So if we modified them, how effective would that be? And that is the data here in these clear bars. And what we see is that by adding even just 5 mutations to a panel of, which can be 20 to 40 mutations, then you can increase the efficacy of identifying South and other Asians as having CF up to 70, almost 90% sometimes. And so it can lead to a big and substantial increase. But these differences in CFTR variants also drive therapeutic disparities in Asians. Now, in 2019, there was what we call a breakthrough drug that was approved by the FDA. It's called the triple combination CFTR modulator that felt was really going to change the game for CF. And it was touted as being a treatment for approximately 90% of patients with CF. Well, where does that claim come from? Well, that comes from the fact that in these registries, that about 90% of individuals have at least one F508del CFTR mutation. But when, again, you look at the demographic breakdown, that's mostly represented by the white population. And when you look at South and other Asians, only about 40 to 50% of those individuals may have at least one copy of the F508del mutation. And what we then did is took that data and said, well, what percentage of individuals within these registries would qualify for this new treatment? And what we found is, on average, about almost half of South and other Asians would not qualify for this treatment because of their genetic profile. So while it's fine to say, well, it's not fine to say that 90% of patients with CF may benefit, it's actually about 90% of white CF patients would benefit. And when you look at other groups like Asians, a much lower percentage of people. And the problem is only going to get worse. So here's a screenshot from the CF Foundation's drug pipeline for CF. And what you can see is that the majority of the therapies that are either available to patients or in late phase trials are CFTR modulators or correctors that require you to have at least one F508del CFTR mutation, which many individuals that are Asian don't have. There is one trial looking at nonsense mutations, but that's a G542X, which is more predominant within white individuals. So almost about, on average, about 4% of persons in these registries have this mutation, which is part of the reason it was targeted. However, it is very rarely found in Asians in the UK, Canada, or US. And so really from this list, only gene therapy treatments would be of benefit to the large proportion of Asians with CF. So in summary, what we found is that CF does occur less frequently in Asian subgroups than white individuals. However, due to the large population of Asia, there are many more individuals with CF than we currently appreciate. And not all Asian subgroups are going to be the same. As Malathi sort of indicated, we were sort of handcuffed a little bit by the data that we had available to us. We would love to do more analysis on refining those subgroups. And so disaggregation is important. And then what we did show that is that there are distinct CFTR mutation profiles within Asian subgroups compared to white individuals that have CF. And this puts them at a disadvantage for both diagnosing and treating CF. And this will affect a large population of the world. About half of that Asian population globally will be without treatments. And these disparities will only continue to get worse unless we really take different strategies to solve this. So with that, I'll end.
Wonderful. Thank you so much, Malathi and Zach, for this really thought-provoking presentation. If you have questions, please put them in the Q&A session, and I'll just start. There's a couple already there, but also just start with a quick one. We have about maybe 10 minutes for the Q&A, but really intriguing. So one question I had, which I think is on the top of the mind, is in terms of taxonomy of the term Asian American, or when did that, in terms of the definition and who we're talking about, is it solidified in terms of health researchers? So you use that term, is it well defined? And then the flip side is, in terms of genetic basis of disease, there's a lot of reports that say that the basically observer's assignment of a culture or a place actually is so variable given the genetics and because of the pass through of each of the different countries, that actually it's easier just to do the genetics. And so I wondered if you could talk about the term and how would you then solidify it, and also going forward, what's the best way to actually get the best data that Zach has talked about, the best database, because that's really the goal, right?
Yeah. So first of all, it's a great question. The term Asian American originated in the 1960s, and it's been used pretty consistently by health services researchers since then. And it includes all of the people from East Asia, South Asia, and Southeast Asia. And again, 85% of them are from the big six. So, Chinese, Japanese, South Asia, Korea, Vietnam. Is that six? I think that's six. And the rest are the long tail from a lot of them from Southeast Asia that are not captured until recently in a lot of different databases in a disaggregated manner. So in terms of how much is nurture and how much is nature, I think that's always an open question. I think it's not any different between groups.
Right.
The more westernized the lifestyle, the more Western type of diseases people have. I guess it's more of a sedentary urban lifestyle is better, I think, than saying a Western lifestyle. And we see that changing in terms of risk factors and the types of problems that people have within their country of origin or their family's country of origin. And we also see those things generationally when people move from one country to another. So we've got about 6 projects that are ongoing, looking at the health risks of people who are from one, from death certificate data of what people died from in different countries with people who are identified as being within that racial group. And the codicil to that also is that there is people who are multi-ethnic, and the multi-ethnic population is increasing dramatically, especially amongst Asians in the U.S.
Right. But if you talk about people from South Asia, and you actually took 100 of the people that were classified as that and did whole genome sequencing, how uniform would they be relative to other people from the other subdivisions in terms of the data? Like, would they be similar? Would they be more similar to each other than other places, or because that's what we're trying to get at in terms of genetics, right?
That I'm not able to answer. That's not my area of expertise. Perhaps Zach can take that question. I've got some general thoughts, but Zach's much more of an expert.
Yeah, no, Tony, it's a great question. And I think what I'll just say is, at least in CF, we need a lot more genetics throughout Asia, right? All the data I showed you, again, was from the UK, Canada, and sort of US, and trying to extrapolate that to what's happening in actually South Asia, right? And so, but it was a start. It's all that we sort of had. But I think what we need to then do is take that information and say, how do we design cost-effective genetic testing? And do we need to, there's been an argument to say, well, we should at least start with whole genome sequencing of CFTR to get a better sense of what's happening there. But then can we tailor it to panels? Or do you do an approach like we said in theory, you could just take an existing panel, add some additional mutations, and then have a reflex if it's not picked up on that, then do whole sequencing, which is what we do in California to essentially use a panel as part of our newborn screening, panel, and then reflex to whole sequencing. And that works well because we have this very diverse population, right? So I think we can utilize those strategies internationally, but there has to be funding for that to happen, right? And you have to recognize that CF could exist in the first place. So since it's not part of newborn screening,
right
there, then you have to be thinking that if someone presents with a CF-like symptomatology, that it could be CF, and then initiate some testing.
And then just to follow up, would a 508 deletion with someone from a South Asian background respond the same as someone with a 508 deletion who's from the white population?
Yeah, so that I think also gets into that we're learning a lot more that the constellation of symptoms that you have in CF are not just due to the primary CFTR mutation, right? We all have, all of us that take care of CF patients have siblings, twins, and things that have the exact same CFTR mutations, but can have very different symptomatology and outcomes, right? So there are clearly disease modifiers, whether it be genetic or sort of non-genetic, that are playing a role here, right? So big picture, we need a lot more information, you know, but we need to start somewhere. And I think that first identifying that these patients even exist, you know, diagnosing them, because even if we don't know their mutation, there are treatments that we can do to improve their care, right? Even without that genetic information.
Exactly.
But we do need that genetic information as well.
Yeah, that's so interesting. One question, how does CRISPR affect all this? Don't they just replace it with a good copy?
Yeah, so, well, it depends on the approach you take with CRISPR or other gene therapies. Let's sort of talk broadly about gene therapy, not just sort of CRISPR, but if you target only F508del mutations, then you're going to be in the same boat, right? You're only going to be affecting a subset of the population. However, if you take a CFTR mutation agnostic approach and say, we're going to improve or replace the entire CFTR gene, then it doesn't matter what gene mutation you have, you're fixing the whole gene, right? Now, there may be other modifications that have happened since then, but I think that's where we find that the CFTR mutation agnostic gene therapy approaches are going to be much more equitable in their ability to help individuals. And I'll just sort of say that this finding of ours about these disparities in CF diagnosis and therapeutics isn't just in Asians. It's in Hispanics, it's in Black, it's in all other sort of minorities, because again, the information that we've been working off of mostly comes from non-Hispanic white individuals. And those are the people that benefit the most from these treatments.
So we have 2 more minutes, and just to ask the usual question at the end of us is, you know, if you were to have unlimited resources for your center, what do you think the most immediate need would be to make the greatest inroads for the care program? Malathi, do you want to start it? Just for a quick.
Gosh, so one major need. I think that we need more faculty to lean into research around Asian health outcomes. What we're lacking is data, and we're lacking good outcomes. So the whole field needs is having increased emphasis, but we need more people to study it.
Great. So then funding to attract new faculty members and their research programs.
Mm-hmm.
Great. Zach, you have a wish list?
Yeah, I mean, I think there are some quote unquote relatively simple things we can do. I mean, Malathi mentioned we found out, like even here at Stanford, we don't disaggregate data in our EHR, right? Like, let's start like with some of the seemingly obvious sort of things, and let's make sure that all of the data that we start working with are being disaggregated. Now, there's going to be a cost to that, sure, but it's important, right? But then I think specifically for CF, we need to be getting, you know, putting together programs, diagnosis programs, genetic, sequencing programs that will work in the areas that we're interested in, right? So if we want to look at South Asia, let's use India as an example, what kind of program will work there? We can't have a real expensive test that we're going to go across all the individuals, right? We need to think smartly about that. And I think we can use Fund Smartly to say, let's, modify some of these panels. Let's, make these diagnoses cheap. Let's do education to ensure that everyone knows that they can get CF. And these are the symptoms that, they need to be on the lookout for. Create registries, right? Just,
Exactly.
Start to gather the data. We need more data.
We need more data in all the fields. And I would also put a plug in that if you are interested in working with our scholars, as Dr. Sellers has done so beautifully, we will be taking 16 mentors about every year, and a proportion of those we're reserving for maternal fetal medicine and pediatrics.
Great. With that, I think the last comment from the anonymous attendee was, yes, let's disaggregate. And I think that's a great way to end today. Thank you very much. We thank Dr. Srinivasan and also Dr. Sellers for this great presentation. Again, to alert us to the differences in these different patient groups, especially, and then to really highlight the care program. And so if you're a mentor, or you want programs, or you have any sea grants, or you have a vision for this, please contact them today. So thank you very much, and we'll see you next month. Thanks again.
Thank you so much.